Okay, so the last thing we're going to talk about today is what to do if patients cannot take in enough nutrients. Well, the first thing we might do is oral supplementation. So we might supplement specific nutrients. So quite a few people are taking over-the-counter nutrient supplements. There may be some prescription nutrient supplements. If they're not taking in enough calories, we can do calorie supplementation. Usually those are in the form of shakes. And then we have meal replacement, which meal replacement is intended to replace calories and nutrients for that meal. So if they're not able to take in enough food orally, then we can move to putting food directly into the GI tract. So that's enteral feeding. Enteral feeding may be, it may go into the stomach, may go into the jejunum, the first section of the small intestine, go directly to the small intestine. So for gastric feedings, we may have a nasogastric tube, okay? We may have an orogastric tube, or we may have a PEG tube, a percutaneous gastric tube. PEG tube is surgically inserted, so that requires a surgery. So it tends to be for more of a longer term issue. An NG tube or an OG tube, there's a risk because we have a tube that's holding the esophageal sphincter open. There's a greater risk of regurgitation and aspiration. PEG tube, we have the risk of surgical placement. So how do you measure an NG tube or an OG tube? You're going to go from either the mouth or the nose. You're going to go to the tip of the ear and then down to the xiphoid process, mark that tube. That's where it's going to go. Okay. Safe placement. We never are going to attempt to place an NG tube or OG tube in a patient who's had facial trauma. If you don't understand why, go and look for pictures of cerebral NG tubes. If we have facial trauma or head trauma, we may have broken bones in those facial bones that are pretty thin, and that tube can get between them and go up and end up in the brain instead of in the stomach. When we place an NG or OG tube, it needs to be verified by X-ray before it's used. And then there are some bedside verification checks that we can use. Anytime someone has an NG or OG tube, the head of the bed needs to be elevated to try to decrease the risk of regurgitation and aspiration. One of the ways that we're going to check placement at the bedside is going to be by aspirating some of the liquid that we get that's in the stomach. If we get something back, does it look like it belongs in a stomach? And then we can check the pH level of that, and it should be pretty acidic. A common way of checking placement is actually not recommended and has a high risk of being inaccurate, and that's to place a stethoscope over the stomach and push a bubble of air into that tube. And if we hear the bubble of air, we would assume that it's in the stomach, but it is possible to hear that bubbling even if it's not in the correct location. So that's not the ideal way to check placement. And first time before it's used needs an X-ray. So same thing with a surgically inserted PEG tube. It needs to be placement needs to be checked by X-ray before it's used. We need to be aspirating and checking to make sure we're getting things that should be in the stomach when we use it. Head of bed needs to be elevated. Sometimes or frequently when they place a PEG tube, they actually do a fundoplication. They take part of the stomach and staple it up around the esophagus to make regurgitation a lot less likely or impossible. So that decreases the risk of regurgitation and aspiration then. So they can also do a nasoenteral tube that starts in the nose and goes all the way down to the small intestine. And they can also place a tube that goes into the small intestine. The reason you need to know that is when you're putting stuff into that tube, if you're putting stuff into a stomach, you've got a lot more space. If you're putting stuff into a small intestine, there's a lot less space before you can potentially rupture that intestine. We never want to push anything into a tube by force. We want to put things in by gravity or use a pump. Feedings with a gastric or intestinal feeding tube can be done in different ways. We can do continuous feedings, and that's usually what we start with. They just run the pump continuously at a certain rate, gradually increasing that based on tolerance. We can go do bolus feedings, and if someone still has a fairly active life, bolus feedings tend to fit in better to that life than a continuous feeding. So bolus feedings are at scheduled times. A specific amount of food is fed in through the tube. Bolus feeding should be done by gravity using a large bore, like a 60 cc syringe. Whenever we use that tube, we need to flush it with water or normal saline. Most of the time we're going to use water. Flushing makes sure that they're getting adequate hydration, but also keeps that tube clear so that it doesn't clog up and have to be replaced. We can also do supplemental feedings, which is commonly done for people who have a hard time getting enough calories in. Maybe they have absorption disorders. I've seen cystic fibrosis kids that have absorption issues do this quite a bit. So during the day they eat, and then overnight usually they do supplemental tube feedings to try to get more calories in. If their gut will not tolerate feedings, then we can go to parenteral feeding. And parenteral feeding is IV nutrition. A concentrated dextrose solution is used as the base, and then other nutrients are added. Okay, lipids may be added to that, or they may be a separate infusion. They require a specific filter. This is called TPN, or total parental nutrition. TPN needs to be given through a central line because the sugar concentration is going to damage those smaller peripheral veins. We want to give it into a central line because it's going to be more diluted and cause less vascular damage. TPN is a 2-nurse check. We need to give meticulous site care and use really meticulous technique, aseptic technique, because that sugar is a bacteria medium. So we can end up with sepsis very easily. We can also, our patient can have hyperglycemia because we're giving that concentrated sugar solution. And if they have a functioning pancreas, the pancreas is making insulin to cover that sugar. So if their bag runs out and the next bag is not there yet, we can have hypoglycemia. So parenteral feeding is riskier, and it has a lot more safeguards. All right, that is it for nutrition, and that's the last lecture for this unit. So study, you really need, for all the lectures in this unit, you don't just need to know the information, you need to be able to apply it in patient scenarios. Okay, that's what your questions are going to be. All right, good luck on the exam.